The lecture today is about artificial teeth selection for complete denture construction. Now, in order to start teeth setting, we need to have some information beforehand. So we need to know the form of dental arches from the casts. We need to know the height and orientation of the occlusal plane, the vertical and horizontal relations between the maxillary and mandibular casts, and also normal facial landmarks. The normal facial landmarks that we need to know around the oral cavity are the nasolabial angle, the nasolabial sulcus and fold, the philtrum of the upper lip, the vermilion borders of upper and lower lip, the corners of the mouth, and the mentolabial sulcus. As you know, these facial landmarks are very important in order to select and also to set the teeth. For example, the lips vary in length, thickness, shape, and mobility between different patients, and this will affect the degree of visibility of upper and lower teeth. Completing about normal facial landmarks, look at the first picture here. When the mandible is at rest, you can see this patient is an edentulous patient and the upper and lower lips are collapsed in. The nasolabial sulcus is deepened here, and the nasolabial sulcus, as you know, is created by the zygomaticus muscles. When the nasolabial sulcus is properly supported by the flange of the upper denture, it will be created. So it's important to know that we have to keep the nasolabial sulcus of the patient, not to eliminate it by thickening of the denture flange or deepening the nasolabial sulcus by unsupporting the upper denture. So we have to keep this normal landmark. Also, you can see in the picture on the right hand side, upper and lower lips are fully everted because they are supported by the teeth and their flanges in the upper denture. Now, as you know, the cheeks and lips are made up from muscles. The buccinators make the cheeks and the orbicularis oris makes the lip. Both of these muscles form a functional unit that depends on the position of the dental arches and the labial contours of the mucosa or the denture base for effective action. So to restore the facial expression, both muscles, the orbicularis oris and the buccinators, need to be well supported by the flange of the denture. As we said in the previous slide, the flanges of the denture give support to the orbicularis oris muscle and also to the buccinator muscle. Also, the teeth give support to these muscles. As you can see in the picture on the left-hand side, the upper lip rests on the labial surfaces of the upper anterior teeth, and the lower lip rests on the labial surfaces of the lower anterior teeth and the incisal edges of the upper teeth. Reproduction of the horizontal overlap of anterior teeth is very essential to produce proper lips contour. We will talk about the horizontal overlap in our next lectures. The picture on the right hand side shows the relationship between upper and lower central incisors in both vertical and horizontal dimensions. This relationship is called the incisal guidance angle. This angle is formed by the path followed by the lower central incisor along the palatal surface of the upper central incisor as measured with the horizontal plane. So this angle is formed by the path followed by the lower central incisor with the horizontal plane, and this angle is called the incisal guidance angle. This angle is very important in the setting of anterior teeth, and also it's very important in the complete denture construction, as we'll see in the following lectures. As I said before, we need some information from the jaw relation step before doing the selection of teeth and also to proceed with setting of teeth. So the carved occlusal rims which we get from the clinic should provide reliable guides for the placement of the teeth. These guides include first guidelines such as the midline, the high lip line, and the canine line as made on the wax rim depending on landmarks in the patient's face and mouth. Also, we need to know the orientation of the occlusal plane during the jaw relation step. Here you can see the Fox plane. The orientation of the anterior occlusal plane must be parallel to the interpupillary line, and the orientation of the posterior occlusal plane must be parallel to the Camper's line or to the ala tragus line. The knowledge of normal anatomical landmarks will help us to provide proper lip support, to know the normal nasolabial angle, to know the vermilion borders, where they should be located, how they are supported. All these information will help us to know the size of teeth, to know where to place the teeth, how to select the teeth. We will talk about this later on. We need also to decide the proper incisal show for the patient. As you know, every patient has a distinct incisal show. Also, we need to know the proper vertical dimension of occlusion and centric relation for that patient before proceeding with teeth selection and setting. Now, after getting the vertical dimension and the centric relation verified for the patient, the lab technician will start the arrangement of the teeth to develop facial and functional harmony. So the basic guides in teeth setting are, first of all, to select the artificial teeth, anterior and posterior teeth, to know the horizontal orientation of anterior teeth, also to know the vertical orientation of anterior teeth, the inclination of anterior teeth, harmony of anterior teeth after their setting, and the correlation of aesthetics and incisal guidance. We will cover all these topics in this lecture and the coming lectures as well. Now, in order to select the upper anterior teeth, we usually do the selection for upper anterior teeth. So first we will talk about the size, and when we talk about size, we're talking about the width and the height. For the width, we measure the width of the upper 6 anterior teeth, not for a single tooth. So the width of the upper 6 anterior teeth should have sufficient width to extend in the dental arch to the corners of the mouth. They should fill the corners between the corners of the mouth. Regarding the height, the smile line will determine the height of the teeth. In order to determine the size of the upper 6 anterior teeth, we can use either pre-extraction records or post-extraction guidelines to satisfy aesthetic and functional parameters. These guidelines are the anatomical landmarks. Regarding the pre-extraction records, they can provide good information, but we have to keep in mind that these pre-extraction records may have some biological changes, such as wear or bone resorption, or teeth showing, so we cannot depend on them absolutely when we select the teeth. The pre-extraction records include diagnostic casts before the extraction of teeth, and these will provide excellent information on the shape and size, the height and width of the anterior teeth. Photographs. When we use photographs, we need good photographs of good quality, and they must show the upper 6 anterior teeth. And we can do a normal mathematical equation. So the width of upper 6 anterior teeth in the photograph divided by the interpupillary width on the photograph should equal the width of upper 6 anteriors divided by the interpupillary width, the actual one measured on the patient's face. Okay, so we need to have excellent photographs showing the upper 6 anterior teeth and to do these measurements on the patient. The third pre-extraction record which we can use is the radiographs of the patient to measure the size of the teeth on the radiographs, but we need also these radiographs to be excellent and of good dimensions, and radiographs might be distorted, so they are not of very good information for teeth selection. Also, we can use extracted teeth. These provide excellent information about size, but about shade, they don't provide very good information because after extraction, teeth dry out and they change their shade, so we cannot depend mainly on them to select the shade. Photographs and casts of a close relative, such as the daughter, son, grandson, they can give good information to select teeth for our patient. Also, we can use old dentures if the patient is satisfied with the size of his teeth in the old denture. We can copy this information on the new denture. Using post-extraction guidelines, as we said, the anatomical landmarks, the teeth should satisfy aesthetic requirements and functional requirements as mentioned here in the slide. So the anatomical landmarks we use to select the size of upper anterior teeth include, first of all, the ala of the nose. As you can see here in the picture here, a dental floss is extended from the inner canthus of the eye alongside the ala of the nose to the upper wax rim. This will demarcate the position of the cusp tip of the canine. Another anatomical landmark that can be used is the corners of the mouth. When the patient's at rest, we can mark on the wax rim where the corners of the mouth are, and this will give us an indication of the distal surface of the canine. Also, the position of the canine eminence or the buccal frenum on the cast can be used to decide the position of the canine, and from here we can know the width of the upper 6 anterior teeth. In this picture, you can see a flexible ruler used to measure the labial circumference of the arc from one canine tip to the other canine tip. Here you have to tell your technician that these marks are the cusp tips of the canine, and when you take the corners of the mouth as your reference landmark, you have to tell your technician that these marks represent the distal surface of the canine. Now, the teeth molds usually for anterior teeth give dimensions from the distal surface of one canine to the distal surface of the other canine. 8 to 10 millimeters should be added to the above measurement to cater for the distal half of each canine if you use the tip of the canine as your reference.
So to conclude, the upper 6 anterior teeth should appropriately support the upper lip, and they should occupy the area of the upper anterior arch bordered by the corners of the mouth. And there sometimes some individualizations might be indicated, such as rotation or spacing, as in the picture here. Incisor A is unprepared while incisor B is adjusted to suit the patient by grinding away the incisor translucency. Facial proportions can also be used to help in the selection of the size of upper anterior teeth. For example, anthropometric cephalic index can be used where the width of upper central incisor is equal to the head circumference divided by 13. Another index, which is Berry's biometric index and Pound's formula, found that the width of upper central incisor is equal to the bizygomatic width divided by 16. These can be measured on the patient face and patient head and are related to the size of the central incisor. So these information can help in the selection of the size of teeth.
Here in this slide, you can see how the ala of the nose coincides with the tip of the canine on both sides, and also the width of both central incisors coincides with the width of the philtrum of the upper lip. This is how we use the anatomical landmarks to decide the size of anterior teeth. Another thing we need to select is the form or mold or shape of anterior teeth and copy this information to the lab technician. There are different forms of anterior teeth which we can select from. These forms are either a square form, tapering form, or ovoid form. and the form of anterior teeth should be in harmony with the face but not identical. There are suggested guidelines, but they have no scientific basis, and these guidelines showed that the shape of the upper central incisor correlates with the shape of the face inverted, or it correlates with the outline of the upper arch. But as I said before, no of these guidelines have scientific basis. According to Leon William, the shape of a central incisor should be in harmony with the shape of the patient's face. So Leon Williams in 1917 stated that the shape of the crown of upper central incisor corresponds to the outline of the face inverted. And the classification of face forms are square, tapered, and ovoid. And according to that, the teeth will have a square, tapered, or ovoid. So patients with a square face outline should have a square teeth shape. Patients with tapered square face outline should have tapered teeth, anterior teeth, and patients with ovoid face outline should have ovoid teeth. This is what Leon William stated in 1917.
So according to William's face shapes, a square tooth shape will fit a square face shape, a tapered tooth shape will fit a tapered face shape, and an ovoid tooth shape will fit an ovoid face shape. But again, this has no scientific basis.
Another theory states that the shape of upper teeth correlates with the shape of the upper dental arch. So, a square arch should have square anterior teeth. Tapering arch should have tapering anterior teeth, and an ovoid arch should have ovoid anterior teeth. Also, using face profile, if we look at the face in the sagittal plane or from the side, you can see the first one is convex, the second one is concave, and the third one is um, concave. Okay, so the profile of teeth should correlate with the profile of the face. All of these are theories, but we can use them during the selection of teeth. In this picture, according to Williams' guideline, the teeth shape should be tapered because the face shape is tapered. But you can see that the teeth are square. So here you can see that there's no scientific evidence for this theory, but we can use it when we select the teeth.
Now the clinician should assess the facial profile in three-dimensional way. This involves incorporating the frontal and lateral views plus another view taken from behind the patient looking down the face in order to determine an overall view of the dentofacial profile as seen in the picture here.
During teeth selection, we should also keep in mind that the sex, the age, and the personality of the patient will affect the selection of teeth. So, in females, the incisal edges are more rounded and the teeth have less angulation than in males, where the incisal edges are more angular and teeth have angles. The age of the patient, old people usually have braided teeth with worn out contacts, so the placement of contour teeth may look artificial. The color of the teeth also changes with age and they turn darker, so selection of bright teeth will look artificial and people will know that these patients are having dentures or artificial teeth. The personality of the patient should be reflected on their teeth. So more squarish, large teeth are selected for vigorous people, while anteriors should be in a flat plane, smaller and more symmetrically arranged for delicate people. We talked about the size, the mold, and now we'll talk about the shade of the teeth. The shade should blend with the face. So young people have lighter teeth, while old people have darker and opaque teeth due to the deposition of secondary dentine and consequent reduction in the size of the pulp chamber. Smokers also have discolored teeth due to stains. The color of the teeth chosen should be in harmony with the complexion of the patient, and the color of the face is more important because the teeth fall into the framework of the face. Now we will talk about the factors that affect the setting of upper anterior teeth. The first factor is the alveolar ridge resorption and the amount of alveolar ridge resorption, the amount and orientation. As you all know that anterior maxilla resorbs upwards and backwards, while the anterior mandible resorbs downwards and lingually. This will be reflected on the position where the artificial teeth will be set. So maxillary anterior teeth are placed forward and inferiorly, and the central incisors are 8 to 10 millimeters from the incisive papilla. Here we use the incisive papilla as a landmark to locate the central incisors during setting. Also, aesthetics affect the setting of upper teeth. The lips should be supported by the teeth, as we said before. The amount of tooth showing should be about 2 millimeters, and this depends on several factors, as we said before. The length of the upper lip affects the amount of the show. As you know that the incisal third of the central incisor supports also the lower lip, and the lower lip pressure causes instability of mandibular denture if the teeth are placed anteriorly. This is how aesthetics affect the setting of teeth. Phonetics also affect the setting of anterior teeth because speech is affected by the position of teeth and the contour and bulk of the palate. The incisal edges of upper anterior teeth should contact the junction of the oral mucosa and the transitional epithelium of the lower lip during gentle smiling and when the patient pronounces F and V sounds. Now, during setting, we should know the horizontal orientation of anterior teeth or the anterior-posterior position of anterior teeth. The guidelines we have from the wax rims will provide us information about the horizontal orientation or the anterior-posterior position. These guides are first, the lips should be supported to restore the facial contour. The landmarks around the lips are the nasolabial angle, the vermilion border, the nasolabial folds, all these landmarks which we talked about. Also, the maxillomandibular relationship influences the horizontal orientation of teeth in class 2 and class 3 patients. The labial plate of alveolar processes. Teeth usually follow the labial plate of alveolar process. Also, as we said that the upper central incisors are 8 to 10 millimeters in front of the mid of the incisive papilla, and if we draw a transverse imaginary line crossing the cusp tips of upper canines, it should cross near the midline of the incisive papilla. The top picture here shows the upper central incisor as it comes from the denture. You can see here why it is 8 to 10 millimeters. So 8 millimeters as measured from the neck of the tooth to the center of the incisive papilla, and 10 millimeters as measured from the incisal edge of the tooth to the center of the incisive papilla. The two pictures down here, the first one on the left hand side shows natural teeth and an imaginary line drawn between the cusp tips of the canines, and you can see that this line passes through the center of the incisive papilla, and we can use the incisive papilla as an anatomical landmark to locate the position of both canines. The vertical orientation of anterior teeth is decided also by a number of guidelines. The first one is the lip length. So depending on the length and also the mobility of the upper lip in relation to the dental arch, this will decide the vertical orientation of anterior teeth. So if the patient has a long lip, teeth may not be visible. Also the smiling. behavior of the patient. During normal smile, the incisal and middle thirds are visible in almost all patients, while the cervical third is only seen in 50% of the patients. The mandibular incisal third is visible in most patients, and in old people, especially men, they show more in the lower teeth than the upper teeth. Also, the incisal edges of lower canine and cusp lips of the lower first premolars are even with the lower lip at the corners of the mouth when the mouth is slightly open or when the mouth is at rest. So these guidelines will provide us information about the vertical orientation of anterior teeth, and they will help us to set the teeth to be in harmony with the patient's face to satisfy aesthetics and also function. The inclination of the anterior teeth during setting is affected by the inclination of the labial plate of bone. As we said before, usually teeth are parallel to the labial plate of bone, and also the profile form of the patient's face is usually representative of the natural anterior tooth inclination within the oral cavity. So patients with a concave profile have their teeth inclined different than patients with a convex face profile. After selecting and setting the upper six anterior teeth, there should be harmony in the general composition of the anterior teeth. This harmony must be present between the incisal show and the patient's age, and also there should be a harmony of teeth with the smiling line of the lower lip, so the incisal edges of upper teeth follow the curvature of the line formed by the lower lip during smiling. Also, there should be a harmony of the dental arch form after setting and the form of the residual ridge. The picture here shows the smiling line of the lower lip, which means the shape of the lower lip during smiling. There's another line which is formed by the upper anterior teeth, and this line should follow the curved line of the lower lip during smiling. This is the natural appearance. Also, the vertical positioning of upper canines is responsible for the shape of the smile line because it forms the beginning of the smile line on both ends. There also should be harmony of the dental arch form and the form of the residual ridge. So a square arch form, the central incisors are on a line with the canines because the arch is wide anteriorly. The incisors should have little rotations to give broader effect to teeth. The second one, the one in the middle, is a tapered arch form where the central incisors are at a greater distance forward from the canines because they're following the shape of the arch. Rotations and lapping of the teeth might be needed in order to accommodate the shape of the arch. The third one, the ovoid arch form, the teeth are seldom rotated and they show a greater amount of their labial surfaces, and they have a curved appearance because they're following the ovoid arch form. We don't only select anterior teeth, we also select posterior teeth types and molds. So according to Lang, posterior teeth are of four types. They are anatomic, non-anatomic, 0-degree teeth, or cuspless teeth. Another classification of posterior teeth according to their cusps, we can say cusp teeth, so teeth with anatomic cusps, or cuspless teeth, which means flat occlusal surfaces, no cusps there, or hybrid teeth, which means combination between cusp teeth and cuspless teeth. The factors that affect the selection of posterior teeth are occlusal factors, stability of the dentures, and aesthetic factors. We'll talk about them separately. How occlusal factors affect the selection of posterior teeth. Now, if you have a patient who only performs vertical mandibular movements during chewing, then it is possible to use cuspless teeth for this patient because he doesn't move his mandible in the lateral positions. On the other hand, if the patient performs remuneratory mandibular movements, when you watch the patient eating a biscuit or a piece of carrot, then teeth with cusps will be required for balanced articulation and stable dentures. So he's doing more movements of the mandible, so we need more cusps. Examination of current dentures assist in the diagnosis to know which teeth the patient needs. So if the dentures have occlusal surfaces that are evenly worn or flat, this is suggestive of vertical or chopping mandibular movements. But if the patient or if the dentures have more wear of the maxillary buccal cusps especially, is suggestive of ruminatory mandibular movements. And in this case, we need to select anatomic or teeth with cusps for this patient. So we check the denture in the patient's mouth. If the occlusal surfaces are evenly worn, then we can use cuspless teeth for this patient. But if the teeth have greater wear, especially on the maxillary buccal cusps, then we need to use anatomic teeth in order to create balanced occlusion during setting. According to stability factors, cusp teeth tend to lock or cause tripping and can aggravate the stability of dentures, while flat, atrophic mandibles, cuspless teeth are prescribed because they do not create any lateral forces and they help to stabilize the lower denture especially. The width of the posterior teeth. If the posterior teeth are too broad, they could encroach the tongue, leading to instability of the lower denture when the tongue is moved. The number of posterior teeth is dependent on the mesiodistal length of the ridge. As a general rule, teeth should not be set on the retromolar pad area, and if there is no sufficient mesodistal length to incorporate two molars, two molars and two premolars without compromising stability, common options are to drop off either one premolar or one molar for that space, to fit in the space. You can see the occlusal tables on this lower denture are too large. The excessive width of the molar is presenting lingual undercuts which will destabilize the denture. In addition, the presence of the second molar on the inclined plane of the ramus will induce a protrusive movement. It's better here to select teeth with smaller occlusal tables and also to drop off the second molar or to drop off one of the premolars from this denture. This slide shows the list of factors that influence the selection of posterior teeth. So teeth with cusps, what are the occlusal factors, what are the stability factors, and what are the aesthetic factors to select these teeth? You can read this table on your own. We also select the material of teeth. There are two materials for teeth. The first one is porcelain and the second one is acrylic. Every material has advantages and disadvantages. The advantages of porcelain teeth, they are hard and glazed, they are color stable, they are not affected by abrasive foods, they ensure good efficiency of mastication throughout the life of the dentures. The advantages of acrylic teeth, they have greater resilience, they are said to cushion the underlying supporting tissues from the occlusal loads. Acrylic teeth form a unit with the denture base resin by a chemical union. This is an advantage. According to the disadvantages of porcelain teeth, they need mechanical retention, they need pins, they are brittle, and they are susceptible to fracture. It has a different coefficient of thermal expansion from the acrylic resin-based material, and unless the dentures are carefully processed, grazing may appear around the teeth and they produce clicking noise during chewing. The disadvantages of acrylic teeth, they wear down with use, and this will result in a loss of vertical dimension. As I said before, they wear down during use because they do not create excessive forces on the underlying alveolar ridges. And this is a good advantage actually. So at the end, after the selection and setting of teeth, the teeth should provide aesthetic requirements and functional requirements. The aesthetic requirements we need from teeth are good and proper tissue support, proper form, color, and size that's in harmony with the patient's face, the position and orientation of anterior teeth, the amount of upper anterior show. The functional requirements from the teeth we need speech and proper pronunciation, stability of the dentures, the position and orientation of anterior teeth, posterior teeth selection, as we said, could be cusp teeth, cuspless teeth, or hybrid, harmony with the surrounding soft tissues, and harmony with the opposing occlusal surfaces. Thank you so much.